statistics. And the subsequent presentations will be more focused on design, particular types of trials, designs appropriate for particular kinds of questions. I'm going to try to provide an overview, some fundamental concepts that you may or may not be familiar with, but even if you are, I want to try to make some subtle points that I think will be helpful, not only for the protocol development, but for the entire future careers that you'll have. So I have some very, excuse me, focused but broad learning objectives. I'm going to spend a lot of time talking about error, variability, and trying to distinguish between systematic and random error, fundamentally understanding the difference and how statistics addresses each one of those, and how you're going to need to account for that in the design of your protocols. I'm going to talk about, which is the goal of much of statistics, methods to minimize error and maximize the accuracy of estimates and decisions, and to talk about how statistical inference, which I'll introduce in a few minutes, quantifies the effects of chance and therefore provides a basis for accurate decision making. Your trials are all asking questions, and at the end, you're going to have to make a decision based on the data that you've collected. And we're going to try to understand how to form the question, how to design the trial, so that at the end, you have a valid trial. You have results that are clear, interpretable, and relevant to the question that you asked. So what is the fundamental role of biostatistics? This is a rhetorical question, but I would say that for us, we're interested in minimizing error, reducing variability. And statistics does that generally in two ways. One is by analysis. The other preferable way is by design. That allows us to increase accuracy of estimates, and the kinds of things we're interested in are treatment effects, dose response, the usual sort of things. We want to estimate systematic effects, treatment differences, differences that are due to specific quantities that I can identify and that I'm interested in. And then to differentiate those from chance, but also to quantify chance. Chance is always going to be evident, and we want to be able to understand carefully how the results that I've obtained are affected by chance. And then to provide a methodology for decision making in the presence of chance or uncertainty. So I'm going to talk a little bit about uncertainty, and there are generally two kinds. One is chance, just random error. Everyone has a very good intuitive feel for this. If I toss a coin 10 times every day for the rest of my life, I'm not going to get the same number of heads each day, just by chance, presumably. And then there's bias. There's systematic error. There are differences that exist that are not due to chance. They're due to specific factors, and frequently that's precisely the question I'm asking. So I want to talk a little bit in this context about accuracy and precision and how bias comes into play here. So accuracy is how close I am to the truth. It's not the same as precision. Precision refers to the ability to, or how closely I can replicate findings if I were to do repeated experiments. How similar are the results of those? That refers to precision. But accuracy takes account of both bias and precision. This is a little bit grainy, but you can imagine I'm shooting arrows at a target, and I want to hit the bullseye. Here we go. That's what I'm aiming for. And I've shot a bunch of arrows, and I've ended up impressing myself because I'm so precise with my shot, right? But I'm not accurate. Right? I always miss. My mechanics are off a little bit. I have a bias. I always miss in the same manner. This is what I want. I'm precise and I'm on target. So that's accurate. So I could be inaccurate because of bias, or I could be inaccurate because of imprecision, even in the absence of bias. So if I'm accurate, so eliminating bias isn't sufficient to ensure accuracy. You've got to eliminate bias and imprecision at the same time. Here, I have the worst case, large bias and low precision. So where does bias come from? It comes from everywhere. Commonly, it comes from a lack of a control group, or at least the lack of an adequate control group. It comes from studying a sample that doesn't accurately reflect the target population that you're interested in. It comes from differential measurement of patients, as might occur if you were not blinded or masked, or whoever was making those evaluations wasn't. And it very often occurs in crossover trials as a residual treatment effect or a carryover effect. I'm going to go through a simple example just to make concrete what specifically we're talking about. And I'll use an example of a thorny problem that has inspired lots of debate, at least in my little world. And that is how to best treat patients who have AVMs that are incidentally discovered. They've not yet ruptured. Should you intervene immediately, remove it, treat it some way with interventional therapy, or just wait, manage the patient, and wait and see what happens? So here are some data that were collected at Columbia University several years ago, single-center data, a large series of patients collected over a very long period of time. And you can see that if you just look at the unadjusted risk of hemorrhage, it's much higher for patients who've undergone an intervention compared to patients who've been treated with conservative medical management. In fact, the risk is about 11 times higher, which is highly statistically significant. But obviously, you don't believe this, because the same factors that account for the choice of treatment account for risk of hemorrhage: size, location, whether the AVM drains. And so there's clear confounding. So you could adjust this statistically and try to remove some of the bias that occurs from having important characteristics being discordant between the two groups. And just by, this is, I think, accounting for size, location alone, but just accounting for those, you can reduce the elevated risk for interventional therapy to about half of what it was. And, but still, there are other factors that I may know, I may have measured, and I may want to account for them. I may know them but not have measured them. And I also may not even know what those factors are. So what do? Well, statisticians have this all figured out. We randomize, right? If you randomize patients to two groups, there's no bias. That is the primary purpose of randomization. It's not balance. Balance is just a nice thing that is likely to happen when you randomize. But you want to remove bias. You don't want any differences between patients treated with treatment A and those treated with treatment B. So you let chance decide how that happens. But not all clinical trials are randomized, nor should they be. So early phase safety studies, dose escalation trials, exploratory therapeutic trials are frequently not randomized, and justifiably so. So there are additional methods that you can use to minimize bias. You can ensure that whoever is making outcome assessments, whoever is evaluating endpoints is blinded or masked to treatment assignment, or it's done by an independent committee. You can retain the subjects that you enroll. That's extremely important. That's perhaps a source of bias that is never fully addressed by statistics, although there are many sophisticated methods that attempt to do so. Compliance with the protocol, that's always important. Complete data collections related to retention of subjects. And then importantly, and you'll hear more about this either later today or tomorrow, I don't remember, but having objective endpoints. You don't want to have subjective endpoints. You want endpoints that are objective and that you can measure with precision. Random error is another kind of error that I want to minimize. All right, so I was talking about bias, systematic error. How do I deal with random error? Well, I can try to select as homogeneous a group of patients as I can, given the question that I have. The more homogeneous, the less variability. I can try to ensure precision by choosing an endpoint that I can measure precisely. I have to, again and again, make sure that patients comply with the protocol, and that if it's a multi-center study, the investigators, the coordinators, everyone understands the protocol clearly, and I can introduce the sample size. That's sort of the easy way to do it, although most expensive. This is just an illustration of how variability is decreased if I take larger and larger samples and I'm interested in estimating something like a mean. I want to switch gears just a little bit and talk about inference. All right, so we talked a little bit about variability, where it comes from, what I can do to try to minimize it. Inference is the way that I take the information that I've collected in a sample and make decisions. And it comes in two flavors. It comes in estimation, which is a point estimate, sample mean, relative risk hazard ratio, or a confidence interval that I'll talk a little bit about in a couple of minutes, which is an interval estimate of the same quantity. And I want you to think about it, and I'll reiterate it again. I want you to think of a confidence interval as a range of plausible values for some parameter of interest. And then hypothesis tests, which we'll talk a little bit about. So let me introduce some of this in the context of a pretty simple example. This is a relatively recently completed clinical trial of blood pressure, strategies to manage blood pressure in diabetics. So patients are randomized to an intensive strategy or a standard one. The endpoint is a composite of myocardial infarction, stroke, or cardiovascular related mortality. And the annualized event rate was 1.87% in the intensive arm, 2.09% in the standard arm. So approximately 12% reduction in risk for the patients treated with an intensive strategy. And it was a large trial, over 2,000 patients in each group. And if I ask, is that enough evidence for you to believe that the intensive therapy approach is better than the standard, you don't know how to answer this without more information, right? What you need is, this is descriptive statistics, you need some inferential statistics. So one way I can do that is to look at the confidence interval. So I have a point estimate, the hazard ratio, which you can think of as a relative risk. And if I combine that with an estimate of its precision or its standard error, I can get a range of values, as I said, a range of plausible values, and that would extend from 0.73 to 1.06, which importantly includes 1. And 1 is a value indicative of no treatment difference. The risk is the same. The ratio of the risk is 1 to 1. So if 1 is a plausible value, I don't have any evidence to think that intensive therapy is better. So it seems all simple, and it is, except that a confidence interval along with a p-value are possibly the two most misunderstood statistical quantities that you'll ever come across. So let's try to understand what it is that that range of plausible values represents. So conceptually, the idea of a confidence interval is simple if you think about it as a range of plausible values. It starts to get a little tricky when I put this 95% in front of it, which reflects the level of confidence I have, which is already a vague statement. Right? It's not a probability, because the parameter that I'm interested in, whatever it might be, and I'll talk a little bit more about parameters so that it's clear what I mean, is fixed in the general frequentist approach. So this has no probability distribution. So when I say 95%, what do I mean? Well, let me try to illustrate it by an example. So what I've done here is I've simulated 50 samples, all with the same sample size. And from each of those 50 samples, I constructed a confidence interval for the mean. And I don't know what this mean is. Well, I do, but you don't. And so you can see that in most cases, that interval includes the true value. But there are three, this one, and that one, where the true value is excluded. So my observed coverage is 94%. So that's what this 95% reflects. If I were to repeat the experiment that I did, which I'm not, but if I were to do that many times, my long-run expectation of how many of the intervals would include the true parameter is that, whatever I've selected it to be. So I don't know for any particular confidence interval. I mean, maybe the one experiment I've performed has resulted in this one. Right? That would be unfortunate, because I would think that the mean was something other than what it truly is, but most likely it's one of these other ones. So we've been talking about parameters. Let's just make a little more concrete what we mean. So a parameter is just some quantity that describes something about a population that is of interest to you. And statistics, descriptive statistics, are simply estimates of those population parameters. So the parameter that I'm interested in is going to be a function of the type of endpoint that I have. So if I have a binary endpoint, success or failure, dead or alive, response, non-response, then parameters like the relative risk or the odds ratio are going to be of interest to me, or maybe the simple proportion or difference between proportions. If I have time to event endpoints, I'm going to be interested in parameters like the hazard ratio or the median survival time. And if I have continuous endpoints, I'm going to want to know something about differences between means or correlations, something like that. So now I want to make a very important point. Everything I've said so far has, of course, been unimportant, but this one is important. And yesterday you were introduced to the concept, hopefully not for the first time, of the importance of thinking. And here's where this comes in handy. So we're talking about quantification of evidence, right? And how I'm going to do it. And my interpretation will directly result from the way that I've quantified things. So here's the important point. The quantification depends on the research objective. And I'll try to illustrate that in a minute. So the same sort, the quantities that I'm interested in when I evaluate therapeutic confirmatory trials or these kind, which I won't dare utter that word, is different than it is for dose toxicity curves, where I'd be interested not so much in confidence intervals, but in things like dose toxicity curves, maximum tolerated dose, minimum effective dose. And for phase 2 or exploratory therapeutic trials, this becomes a very difficult kind of question, right? I don't want to simply look at the same strategy as I do in phase 3 trials, because it's not a phase 3 trial. So I'll come back to that in a minute, but let me introduce first the notion of hypothesis testing, which is something I'm sure that you are all familiar with, some more than others, but it's a very simple idea. I want to make a decision. I want to choose between generally two hypotheses, one that I call the null, the other one that I call the alternative. And the basis for my decision is the evidence that I've collected in a sample. And the null hypothesis, as you know, is most often a statement about the comparative ineffectiveness of a treatment. So in the accord example, it would be that hazard ratio or relative risk is 1. Alternative is generally everything but the null, right? Not 1. And I can have a 1 or a 2-sided test. And you know, I can make two kinds of errors when I do this. And I can have I can make a type 1 error, which would occur, a false positive, when I should have rejected the null hypothesis, but I didn't, or a type 2 error, which corresponds to not rejecting the null hypothesis when I should have. I just want to advance through these for a second. Giving the answers. I have no big deal. There are a couple of slides that I thought I had that aren't here, but I'm a professional, and I'll make the corresponding adjustment. And if I had not gone through this to just to see for myself, you wouldn't have even known. All right. So I have several versions of these things, and I've obviously not kept track. So that was, if you noticed, some sort of indecision. It was confusion. It wasn't. So anyway, I can make two kinds of errors. And just to give an air of sophistication, we use Greek letters to identify the probability of making each one of those: alpha for type 1, beta for type 2, and power is 1 minus the probability of a type 2 error. It's the probability that I correctly reject the null hypothesis. So a hypothesis test has with it always this quantity known as a p-value. And a p-value has a very simple definition. It's simply the probability that you observe a result as or more extreme than that you observed if the null hypothesis is true. So that is, at least, if you just read it, relatively straightforward. I want you to think of p-values as a tool to make a decision. That's when you think p-value, I don't want you to think, I'm going to tell you more about it, but I really want you to think about it as a tool. Right? And you know that it's generally arbitrarily set to be utilized in a decision-making way in terms of whether or not it's bigger or smaller than 0.05. The p-value has been around for a long time, in statistical age, 1925. And it was developed by R.A. Fisher, who thought it was, at least in his original thinking, one factor that you could look at to assess evidence. And 0.05 was sort of just his gut feeling about something that was a reasonable level, but it stuck. And the 0.05 level is a level that has served confirmatory trials very well. But this, even the notion of a type 1 error and what value you should pre-specify for it is attached to phase 3 trials. When you think about early phase trials, it's not even, I think, useful to talk about type 1 and type 2 errors, but to think it's the same thing, but to think in terms of false positives and false negatives. That doesn't have the same baggage of a number on its back. Right? So if you think of false positive rates and false negative rates, what you can tolerate those to be depending upon the type of study that you have, then I think you'll be much better off than thinking about type 1 and type 2 errors. Unless, of course, it is a confirmatory trial. So higher values not only may be reasonable, but almost certainly are reasonable. So if you have a drug that you're trying to take forward, and you have an exploratory therapeutic trial, could be pretty small, 40 patients, 50 patients, 60, 100. To think that you're only going to go forward if you find a statistic that has an associated p-value with less than 0.05, what's the problem with that? Well, the false positive rate that you're willing to tolerate is way too low. You're never going to, well, you're going to throw, your false negative rate is going to be far too high. You're going to eliminate treatments that you shouldn't be eliminating, at least at that point. So, confidence intervals are plausible values, and I tried to illustrate what that was. P-values are remarkably difficult for most people to understand. And I don't know if you're familiar with the ECMO trial, the small one that was implemented in a way that using response adaptive randomization that was a total disaster. But there's a paper published where a bunch of statisticians were asked to analyze those data and to assign a p-value to the results. There's like 11 patients, children in the study. And there were like 12 different p-values, ranging from 0 to 1, which means that the statisticians were certainly right. So, but what does a small p-value mean? This isn't a rhetorical question. We're going to look at more precisely what it doesn't mean. So does it mean that the null hypothesis is false? This is a tough one because this is really, I think, how you think about it, right? Small p-value, oh yeah, the null hypothesis is false. But no, that's not what it means, right? Why? Because remember the definition of the p-value is the probability of observing data given the null hypothesis. That's this thing. So this is not a probability statement about the null hypothesis. This would be, and these aren't equal. So it doesn't tell you how likely the null hypothesis is to be false in this formal probabilistic way. Does it tell you that the treatment effect is big and clinically important? No. Maybe, but not necessarily. Does it tell you that the results are unusual? What you saw is unexpected if the null hypothesis is true? Yes. And that's it, right? So again, I think that it's best to think about p-values as just a tool to make a decision, to choose one or two hypotheses. So let me just illustrate the point that I made, that you could have the same p-value and quite different treatment effects. You could have the same treatment effect and quite different p-values. It's pretty obvious, but on the left is a situation where we're looking at the relative benefit for one treatment compared to another, and in this panel A, it's 10% under these two different scenarios, but for one, the p-value is very small, 0.002, and for the other, it's 0.3. So same treatment effect, wildly different p-values, obviously because of the precision with which I've estimated the treatment effect. Presumably, there are many more patients in that study. Likewise, on the right-hand side, I have a situation where in one scenario, the treatment effect is much larger than it is in another, maybe 10 times larger, yet p-value is exactly the same. So just by knowing, if someone brags to you that their p-value is very small, take it with a grain of salt. So I'm going to finish with power. And adequate power is a cornerstone of good clinical trial design. And the reason is that if you have a negative trial that wasn't sufficiently powered, you don't know how to interpret that. You don't know if it was negative because treatments aren't different, or you just didn't have enough information to determine that. So power should be based on detecting reasonable effects. And this is fairly straightforward and simple if you're defining a phase 3 or confirmatory clinical trial. Right? So you want the effect that's going to change practice or confirm current practice. And you want generally the minimal clinically significant difference. This reasonable effect is much harder to define in exploratory therapeutic trials, but it's something that you'll have to grapple with. And power depends on sample size, the type 1 error rate, variability, and the effect that you'd like to be able to detect. So the more sample size, the more power, the higher false positive rate you're willing to tolerate, the greater power will be, the larger the effect that you're willing to detect, the larger power will be, and the larger variability is the lower power will be. So let me try to summarize what I've said. So biostatistics addresses variability. Through design, we try to minimize systematic error or bias. Design also can reduce random error, as can analysis. You should think of sort of the bread and butter summaries, confidence intervals, and p-values in the following way. Confidence intervals are a range of plausible values for a parameter of interest. P-values are tools to make decisions. All decisions have the chance of being wrong. And most people recognize that, but not everyone. So the important thing is that the risks are quantifiable and under your control. And you can minimize those risks by a careful experimental design that equates the question that you're asking with the summary that is most informative and easily interpretable. And finally, no matter what stage trial you're designing, there are some very key and simple elements that are required for the trial to be valid. Valid means that the answer is accurate. So a well-defined objective and an appropriate design so that the results that you get are unbiased and are clearly interpretable. Having an adequate number of patients to address what you've defined up there, retaining them in the study, and making sure that they follow the protocol. Then I have some references. That's all I have. Thank you.
Thanks, Michael. That's a really great lecture. Sometimes it can be hard for statisticians to get back to the fundamentals, and I think you did that in a really nice way. So I think that the point of this was to introduce you to some of the common language that we have, so that we can speak a common language. I know from, at least from the first meeting with my team, that some of you, this will just be a review, but for some of you, this is probably all new. So as we'll be building on this lecture with the other lectures following this week, this is an opportunity for you to ask some questions if this is new to you. There's also some of the references that were at the end there, I think, are actually really helpful if this is completely new. So the one that was the basic statistics for clinicians, there's a 2-part series to that. It's really easy to grasp. Are there any questions? Yes?